today is a great day. We have Dr. Jay Anders on, Chief Medical Officer at MedComp. This is on Planetary Health First, Mars Next. I'm Michael Mann, the host. And Dr. Jay Anders, could you quickly just briefly introduce yourself? Love that you're here. I love that you're going to be talking about what we're going to be talking about. A lot about getting AI right, really making sure we get it right. And that's with doctors, clinicians at the center always, and really how we can augment, assist, but never at the risk of having or taking that clinician out. Would you say that's about getting it right, where we're going to be talking today?
I think that's spot on.
Please introduce yourself. Yeah, please.
I got into electronic healthcare it's been 20 years. It's starting to date myself a little bit. I'm a general internist by training, and I practiced medicine in that regard for 20 years at a multi-specialty group practice. And then got involved with several companies doing electronic healthcare and electronic healthcare records. I've been working at MediComp now for about almost 12 years. And the reason I got involved with MediComp is they have a system that is AI-based, but it is a curated system. So it's not one of these pure generative AIs that is out there now. So I kind of morphed from doing just electronic healthcare and looking for doctors' workflows to make it easier for them to do what they do every day, to more how do you incorporate some of this newer technology into that such that it is helpful, not hurtful, as well as is an augmentation, not a replacement.
So it is so scary how fast AI is moving and everything from video to Google making motion pictures with VO3, and they probably got VO4 now, right? Yep. And how much is going on and been going on behind the scenes. And so I would imagine healthcare is doing a lot of this. What is the current, worry, if you would? Like, I don't want to scream and yell and have the fire on, but what do you think's happening right now as a clinician? What would you think are areas that they should slow the AI down on?
Well, interestingly, I think when AI's been out for at least 10 or 15 years. It's just now come into vogue the last 4 or 5. One of the things I thought about with AI is AI was a solution looking for a problem. So they're throwing it at just about everything. And I do mean everything from scheduling to equipment management, to writing notes, to helping diagnostically look at medical records, to help bill, to help do lots of different things. So there's a lot of people throwing a lot of things out there right now. One of the things that I think is one of the most concerning is that, well, let's back up. AI has 2 problems. One is trust, and one is reliability. We'll talk a little bit about cost, I hope, too. So these things are prone to hallucinations, meaning if they don't know an answer, they'll just make up something that sounds really good. And sometimes it's really hard to figure out that was a mistake, the way they present it to you. So how they got to the answer you're asking, there is no way to tell. It's like a black box. You ask it a question, here's a set of symptoms. I want a diagnosis, and out pops a diagnosis. You have no clue how that happened. It just comes out with it. So there is a transparency issue. How's it doing what it's doing? So doctors really, you got to trust it. And I don't think physicians are there yet. I don't think clinicians are there yet. We don't trust it to come up with the right answer. Then we talk about replacement of clinicians. I've read just today that Microsoft, after they've poached several Google engineers from their particular AI projects, came up with what they're calling medical superintelligence. And they're using several, I smile, I like it. There are several different models, and they're using this kind of as collaboration. So one model is talking to another model. It's like a group of clinicians talking together to come up with a diagnosis. Now, none of this has been published. This is just some kind of press release. But they said that their particular system, using some New England Journal of Medicine case studies, diagnosed patients 80% better than clinicians. So, okay, granted, I have no clue how they did that. I don't know what the study looks like, but they're touting that these guys, they're creating something that's very accurate. But if you diagnose something 80% of the time, what happens to the other 20%? We're talking about human beings now. We're talking about treating people. And if you're right, only 80% of the time, and physicians can get it wrong too, but the thing that's different about a clinician is they'll keep working at it till they get it right. They'll keep adding to and work on it and get you what you need. So it's a different way of thinking about what do you do about trusting it? What do you do about what you get out of it? And that's why human in the loop is got to be, and I don't care if you're talking about healthcare or computer coding or whatever, it's important to have humans involved with this.
Yeah, I love the word hallucinations. I think that has been the most powerful selling phrase that really I think should be AI lies. It's like almost like beyond hallucinating. I think a hallucination has been a really great tactical strategic terminology play. It flat out is pathologically a liar sometimes. I mean, it's just like it is so well on everything the way it is that it works. So I think sometimes we should really get back to the ground truth of what these terms are. And I don't want to get sidetracked, but I've never felt right with the word hallucinates because it seems like it embellishes, it has a tendency to do that better than any human. You know, your resume is always better with AI, generative AI. Your everything is always so great. So I think that we got to work on another term. Not on this show here today, but I love your other thing that you brought up that I think is so important is this, how are we going to, the trust, to me, the trust factor is everything. And I think AI, as we continue, is going to make the value multiple of a physician clinician go up exponentially. And people are going to want a doctor. And we're actually creating more of a demand for that doctor interface. And these tools are great. We're going to see a amazing, we're seeing a rapid acceleration of these tools, but people want just answers from a doctor. And so anyway, I'll stop because I'm talking too much.
Well, you're right about that. The thing that these medical chat bots is what I'm going to call them, where you ask it questions, it gives you answers, lacks all the human qualities that a clinician sitting with a patient has. And what I mean by that is when I see patients in an office, I watch them walk down the hallway. I can learn more from them walking down the hallway and saying, "Hi, how are you?" than an AI is ever going to do that, because I'm looking, I'm thinking, I'm in the process of gathering information. I'm not judging what the next word's going to be. So that interaction is so important. The other thing is trust. And that's something that's built over time. Now, do I think AI systems are going to get more and more accurate? Yes, I do. Do I think they can be an augmentation to the practice of medicine? Absolutely. Yes, I do. Are they ever going to replace it? No, they won't, because there's still, you need that interactive between the patient and the clinician, that back and forth, that human connection, which goes so far in how you actually treat a patient. The other thing I've noticed that they talk about is the accuracy of diagnosis. So give it a set of symptoms and it will give you a diagnosis for a patient. A diagnosis is only the beginning. What do you do about the treatment? Follow up with that treatment. How's the patient going to be taking the medication or doing the testing or doing the procedures that you're going to prescribe for it? You know, that whole thing. Diagnosis is one thing, treatment is an entirely another thing. And there's a lot of interaction, there's a lot of human back and forth that goes into the actual treatment of a diagnosis. So diagnosis is one thing, treatment's something else. And they will come up with a list of treatments, but how does that patient incorporate that treatment? It can come up with a list. And let's talk about economics for just a minute. So it comes up with a set of medications that this particular diagnosis requires. AI did this. I'm looking at a patient who I know is in a socioeconomic class. There is no way they're ever going to be able to afford that particular treatment plan. I've got to come up with something else based on their socioeconomic position, based on their education, based on a whole lot of other things. So that human in the loop is what I was talking about. When you put that in there, you can take what the AI gives you, which is great. It's helpful. But you got to marry it up with the actual treatment of the patient and how that journey goes from the point you made the diagnosis all the way through.
And then also a lot of the problem too with diagnosis is the actual end result. How you know, I hate to say it, call it the medical billing record. I mean, it's all about getting billed. So there's bias to begin with the whole diagnostics. And you know, I've had some really amazing guests on that are, you know, in the past, you know, and one of the appreciations from one of the clinicians was more from the functional integral medicine approach, you know, like the internist on steroids that could really take that time to figure out the medical mysteries. In the end, the diagnostic codes are limited to the holistic approach, just as you're saying, with those demographics and all the different things that aren't all also, you know, I think the science of how, and I'm not a clinician, so I'm going to stop, but I'm just quoting from one of my, you know, trying to get the essence of that challenge on really the holistic approach is not always, it is a challenge. All the more reason why you need a team-based approach, clinicians at the center of each decision making to get to that process, which is longitudinal. You don't find an answer. Sometimes it could take years.
Sometimes it takes quite a bit of time and quite a bit of effort going back, redoing, rethinking to get to that end point. The other thing that is interesting about this is when you see these systems coming up and being tested and all of that, they're tested in major medical centers. That's where you'll see them: Stanford, Scripps, Mayo, you know, pick a large university-based health system. The medicine is practiced across the country, meaning there is a lot of hospitals, of which my hometown has one, that is maybe 100 beds, and it is not running on multi-million dollars in profit every year. Mm-hmm. So take this Microsoft, you know, the super intelligence of medicine. Who's going to pay for that? They can't. They're having a hard time keeping the lights on in these hospitals. They're running on a very, very slim margin, if any, or not losing money, and they're going out of business right and left. So let's layer on a big bunch of cost on top of that to try to mitigate that in some way. No one's ever talking about that. LLMs cost money. These data centers that are being built across the country are not cheap, and they're being paid for by usage with AI. A lot of it. So think about layering on AI cost to the practice of medicine. Then you got to really think about, is it worth evoking an AI system for everything I do as a clinician? And I'll give you a great example. You come into my office and you've got a low-grade fever, a runny nose, a mild sore throat, and a mild cough. I already kind of know what you have. I don't need AI to tell me you probably have a virus. I'm going to take a look at that and confirm that. I may run a test or two, confirm you don't have a bacterial infection, but it's most likely a virus. Do I need a generative AI system to put all those symptoms in and come up with the same answer? Think about another example, for instance. So patient comes in and they're on treatment for high blood pressure. Their blood pressure is normal on the medication that I have given them. The medication has a few side effects. I'm going to make sure their electrolytes and potassium and their blood tests look okay. Do I need AI to tell me that? Do I need to layer the cost on top of that to treat that patient? In my opinion, the answer is no. I don't need it to be involved with that. So it's where you put the augmentation. Where do you put this in? Let clinicians decide where they need the help. And no one's asking that question right now. They're just saying, here it is. It's going to help you do everything, and boom, take care of it. No one's asking clinicians what they need help with.
I love what you're saying, because I had an amazing guest on last week in the studio, in the green room, whatever you want to call it, the blue room, the purple room, whatever, behind the scenes talking. He's a clinician, ER doc out of Stanford. Also, he has done, he is part of what I call these AI doc enthusiasts, like skilling up. And really what his call and mission was exactly what you're talking about. We need to have doctors at the head, at the seat of the table with this AI before it's released or while it's released. And that safeguards, like no more ER, big time, sitting there in your pajama time for hours and hours. Like that to me is just sort of what I'm hearing, sort of echo of your call, Dr. Jay Anders, is kind of this new, like, we gotta do this, but it's got to be with clinicians and it's got to be done right. Would you say every step of the way? Isn't that what you're kind of? I mean, don't mean to exaggerate, but it seems like we have a huge opportunity here if we get it right.
We do. We absolutely do. And as these systems gets better and better and better, the advantage gets better and better and better. But and this has been this way for a long time in electronic healthcare. Ask clinicians what they need help with. Don't just assume, ask them. Don't assume that they're going to get it wrong 50% of the time or get it wrong 75% of the, whatever that particular, I just voiced the Microsoft thing, but whatever, they're going to get it wrong. Well, don't go after it that way. How do we make them get it right? Mm-hmm. As opposed to, oh, you're going to get it wrong. Throw it to the AI. It's going to take care of it for you. Because I know we're not there yet, and we may not be there in my lifetime. Because I don't think the trust is going to be there, and I don't think it's going to be cost effective enough to put this in every clinical situation.
What is some of your experience with like these AI scribes? I think there's hundreds of them. There's 750 EMRs, right? So some 200, probably 300 scribes. Now there's wrappers, lick offs, whatever. There's just endless. We'll give it to you free if you use or whatever. We'll do a study with it. I don't know. Every day of the week, there's a new whatever. And then doctors aren't even using it. So, or some of them are probably not, because then they spend more time trying to make sure that word's corrected, or they have something like they were in the weeds, talking about in the weeds, and then they're talking about marijuana or something. The next thing you know, whatever. It just seems like sometimes it just doesn't get stuff, and it's causing more problem than but what can we get into the weeds about some of these applications of AI and the good, the bad, the ugly?
Well, this ambient listening technology is what you're talking about, where you hang a microphone in the room, you talk as a clinician, the patient talks, and you get a conversation going, and you ask questions. They give you answers, and the AI pastes it all together at the end. Interestingly, it makes up things in that regard, just as it makes up things in other areas. Meaning, sometimes it has a hard time knowing that I'm a male as opposed to a female. So in the same note, and I've got 3 examples of this with just my colleagues, where in a note, clinical note done by ambient AI, they call him a he and a she 3 different times. They couldn't figure out who he is. He's a he, but they call him a she. The other thing it has real problem with is say, oh, I've had a bad cough, or my mother had a bad cough in the past. The AI all of a sudden figures out, well, maybe I'll just apply that cough to the patient, not the patient's mother. So I've got another example of that, where one person I know has a diagnosis of liver cancer because his father died of liver cancer. He doesn't have liver cancer, but in his medical record, it states that he has liver cancer. Now, here's the issue. When those mistakes get in there, they are like, embedded nails in an old barn. You can't get them out for anything. So when it makes mistakes and the clinician doesn't catch them, that gets in your medical record. That puts patients at risk, because not only at risk for just treatment purposes, but at risk for, they apply for, life insurance. Oh, you got a history of liver cancer? Oh, I'm so sorry, you're denied. We're not going to give you life insurance. Well, I don't have it. Well, your medical record says it does. So there's issues with this. And I actually have talked to a lot of clinicians using ambient listening technology, and some of them really like it. Some of them really don't. But here's the problem at the bottom line. They still have to read it. They have to make sure that what it's produced is accurate before they say, yes, this is in the medical record. And these systems lull clinicians into the trust of, I can do this for you. I can do this, just forget about it. Set it and forget it. Remember the old Ronco commercials where you put the chicken in the oven and set it and forget it? Well, guess what? These systems kind of lull people into that. You still have to read them. You still have to confirm that what they said is correct. And they will summarize within that conversation. That's what they're doing. And it's very difficult sometimes to get those errors surfaced and then corrected. So, to me, I think it's going to save time overall, but it's going to actually give you time having to read notes that you haven't really had to read before, because you either typed them in, clicked them in, you knew what you did, but it's just like reading dictation back in the old days. I would transcribe a note in my office, it'd go off to my transcriptionist, it would come back in a form, either on paper, then on electronic paper, and I'd still have to read it. So is it really helping? It's got the potential of that.
So with the patients at risk, where are obviously the patients at risk with many of those things, just a bad process end result. And then, whether it be a wrong diagnosis, but walk back with us, just kind of overview kind of this, get AI, you've shared multiple times, challenges, it'd be nice if you could just sort of kind of help walk this through right now, what you're seeing, where we are in the inning, what needs to happen to get this right. What do we have to have another committee? I mean, what is this look like to get this right? How do we implement? I mean, obviously we still aren't regulated with 232 as an internet, right? How do we do this to then create one more dang meeting for a doc? What's and of course, the problem is not as bad as the solution almost, or, so just what do we do?
Well, interestingly, the National Health Service in the UK came up with their own criteria, of which there are only, I think I saw 6 or 7, I'm not sure which, systems like this that they will certify, meaning they work within the constraints of their production, and there are certain things you do in the protocol to make them operationally correct. So they went through all of that to demonstrate that we can't just use any old thing. It's got to have rules. It's got to have training. It's got to be overseen as a tool, like anything else, just like a stethoscope is. So these systems have to be there's got to be some oversight. There's got to be some certification. And actually, I've seen regulations in the UK where these are medical devices. And when you elevate something to a medical device, so a pacemaker is a medical device, it has to meet certain standards. These systems also need to be applied just like that. They need to have standards applied to them where they produce certain things with a very high regularity of accuracy, so that clinicians can start to trust them, but they still have to read them. They still have to read notes. They still have to read the output of these things. So I think it starts with regulation, of these systems. Not everybody and their dog can create one of these and make it work. There needs to be oversight by the clinician, physician in the loop, human in the loop. I keep coming around to that, where they're the final arbiter of this before it ever gets out and published in a medical record for a patient.
So would you say, like, obviously, what is it, like a 5K or 10K? I don't know if that's the financial, like, what's the final most robust regulatory, like, I guess there's different levels. Would you think the standard would be create like the lowest regulation within this actual generative or AI meets this, and then probably certain levels of criterion in order to guide clinicians and doctors and organizations?
Well, right now, the national coordinator for healthcare IT has come up with some regulations that are actually very good, and they're in stepped format, meaning that they start out at one level and they slowly increase up with more and more and more constraints on things. But it's a beginning. You're not going to be able to, throw the highest level of like medical device certification on something without, let's go through some process here and see what it's about. We've already started down that road. The government has put together regulations right now that are being slowly rolled out to start to build that trust I talked about in these systems. But still, it's up to the clinician, regardless of the regulation, if your pacemaker fails, your cardiologist is going to know that because they've checked it every 6 months or every year. Same thing is going to be with these AI systems, because they come up with new models, they come up with new calculations, they come up with new prompts, and that also has to be, again, looked at to make sure it met certification criteria. So there's got to be a process, and we're just starting to get that process. The problem is there's a new AI platform that's being created about, once a week. There's a new one of these out there. There's I call the big five, but there's a whole hundreds of these models out there that have to be looked at, and I would say certified or at least validated that they're producing anything close to the outcomes that we need.
Now, I'm going to cry on the other end. Oh my gosh, what about innovation? This is going to stifle innovation. This is like big tech trying to, Amazon and all these big companies trying to stifle the little guy.
Would you want your 5-year-old child innovated on or treated responsibly? That's how I look at innovation. Innovation is a good thing. We would not be where we are if it weren't for innovation. But innovation comes at a cost. And we're dealing with people. We're dealing with human lives. We're dealing with human health. And we can innovate, but we have to validate. So innovation for innovation's sake, I think, is very short-sighted. But innovation with validation is a good thing.
So you're the chief medical officer at MedComp. Tell us a little bit. I mean, you guys are doing some AI stuff. Tell us a little bit about what you're excited about, what you're working on. And I'm sure as you're the chief medical officer, you're making sure you're doing these things.
Well, what we're working on, what we have been working on for over 45 years, is a curated system. It's a graph database, just like all these other databases that AI uses. But right now, what we see as exciting is we are basically guide rails and training criteria for a generative AI system, meaning that it can come up with an answer, but doesn't meet some of the answers in what we have. It's a validation tool, basically, for this. And we've got customers actually doing just that, where they have AI generating these notes that you just talked about, and does it fit in to a structure where real human physicians over 45 years have created a system that has over 6,000 diseases, 100 million links. Does it fit into that? And our particular system is all validated and it's all referenced. We know that if we give you an answer for a particular diagnosis, I can tell you exactly where it came from, where generative AI cannot. So people are starting to look at what we have and say, okay, let's put another box around this hallucinations, or you call them lies.
Sorry.
But let's put a box around that. So when it hallucinates, at least they can tell me that it hallucinated.
Mm-hmm.
Because like you said, sometimes these hallucinations, these are pretty good. They fit right in. So I don't know if that's the case. So that's what we're building right now. And the other thing we're doing is basic clinical data cleanup. There's a lot of stuff, just like I talked about the liver cancer, or it's something's wrong in the medical data. How we can get that cleaned up and get it into the system, because this data is being shared from doctor to doctor to doctor over these QHINs and other health exchanges. So is that data really valid? Is it correct? How can we correct it? Can we tell the person who's receiving it, we've looked at this. These are the 5 things you need to look at. Ask the patient if they really had these 5 things, mm-hmm. and get it correct.
Tell me a little bit about some of your customers. Is it, I know in healthcare is a big space, from, those who maybe not familiar with some of your user case, whether it's life science, payers, providers, or, who are your just if you could just a little peek under the hood, sure. Just a little bit.
So our particular system is installed usually inside of an electronic medical record to collect that data I talked about, making it correct, presenting the user with the things that are related to a particular diagnosis inside that EMR. So it does that data collection inside of an EMR. We also can take any particular set of data. So here's a patient's record. Show me everything in that medical record associated with diabetes. And we can do that. And we can do it without AI, but actually we can do it in a different, more cost-effective way. So we actually manipulate, sort, validate data inside of an EMR. And right now we are getting people from the health information exchanges looking at our stuff to do exactly what I talked about, where how do we clean up the data? We've got something that's errant. How do we surface it and present it to the next person down the road to say, hey, take a look at this, ask the patient, is it correct, is it not? Because right now we can't figure that out, but we can flag it. At least the clinicians will know. So to me, it's all about healthcare data and making it correct and accurate, because that's what we base our decisions on, whether it be AI decisions or whether it be my decisions as a clinician.
It sounds like some of your technology, like if I was a payer, I'd like to use yours to make sure how much of the diagnosis are we getting right. I mean, I could imagine some of these engines, these algorithms, these licensing, let's make healthcare better. The endless or a certain trial for a certain disease. I mean, that kind of knowledge can just be actionable at some point. So I hope, I know you can only talk but so much as chief medical officer about your partnerships and your channel partners and your revenue generation. But you must be in that scope really excited by the possibilities.
Yes, we are. And it's not as if we haven't been approached by having people inquire about that particular aspect. Mm-hmm. One of the things that we can do very, very well is do data mining inside of a medical record. And we can do it at the clinical level at the point of care, but it also can be done outside the point of care to glean out whatever information, because we codify everything. So everything's got a place and a code and a relationship.
How do we not get data overload?
Data overload usually comes from the fact that what you're being presented with is either too much or too disorganized. So what we're about is we can organize that data. Just like I said, show me just the diabetes part of this. Show me just the hypertension part of this. You start to limit I call it clinical noise, mm-hmm. out of a medical record when you've got somebody in front of you so you can focus. Mm-hmm. So you can get a lot of data, but show me the data I'm asking you for, not show me everything.
Yeah. I just see one of the areas that I'm so interested in is sustained behavioral change. I mean, we know so much, but we know we do so little. And when I mean like that, I say like, the 168 hours outside the clinic of XYZ demographic. And, the bottom line is, you have all these functional health, lab results, all these great wrappers that look great, all this great whatever. But the end, I still want my pizza at 7 o'clock, and I know I shouldn't be eating it, or my Dollar Tree, whatever, $1.25 candy that I shouldn't be eating. And those things are so hard. And I know I'm getting off topic, but I think this is real. I think AI really can promise that connectivity, and companies like you with that on diabetes or whatever it be, managing, especially as an internist, you actually were the functional health doctor before they used functional health became real sexy, I guess, after these last year or two. But tell me, like, that as a doctor, I don't know if you're still actively practicing, but obviously your license still real as chief medical officer. Tell me a little bit about that, really moving the patient's behavior and the promise and opportunity. I know that could be a whole nother show or series, but I'll stop there.
Well, what's interesting, there's a lot of studies out there that for certain diseases, multiple touches can really start to move patient behavior and patient outcomes. And what I mean by that is, I'll take diabetes as an example. Usually diabetics who are stable will be seen twice a year. But really, they've done studies where if they're seen either electronically or on the, a telephonic or Zoom type visit every month, that tends to be better control. The thing out there with all the wearables, I mean, I've got one, that's data flowing all over the place. Clinicians do not need to be flooded by a whole set of continuous glucose monitors, which is checking your blood sugar, every couple of seconds. So they don't need to know that. What they need to know is all of a sudden things have been just fine, and now they're not. And you can give it parameters to alert you to that effect. It doesn't have to be you. It could be your staff or your office or a mid-level. But this is where AI can come in, because AI can recognize that this pattern has changed. What's going on here, and alert you to that. That's a really good use of AI, by the way. And it's nothing more than taking a lot of data and crushing it down to something that you can focus on and not overload you as a clinician. Because that's the other thing that's happening right now. I'll use my primary care for an example. She told me the other day she got 50 patient inquiries, this text messages to answer. And I saw her at 8 o'clock in the morning. She had already had 50 in her mailbox for over the weekend. So she had all of that work to do. And now how do I sort that? How do I look at those 50 text messages and try to get to the 3, 4, or 5 that I really should answer right now? And then the rest I can do whenever I can do them, or I can shuttle them off to a mid-level or someone else. So that's a really good use of AI. AI is great at that. So it's all about the overload of clinicians. Please God, don't give them anything more to do, because they've got enough to do, and there's a shortage of them to begin with. So let's help folks get to the care that patients need without overloading them with a lot of stuff that the physician really doesn't need to see.
So as we're wrapping up, Dr. Anders, like, what would be those 5 principles, the sacred space for the clinicians? Like, what would that look like? Like your AI rule engine to keep those clinicians, their sacred, knowledge source, and AI where it needs to be and where the clinician needs to be.
Well, first off, an AI system should never make a decision that goes directly to patient care without a clenicien reviewing it, ever. AI should not create medical records for a patient without a clinician reviewing it and making sure it's correct, ever. There needs to be, you need to understand when you're using one of these systems, where it's coming from and how it's being used, because they all have advantages and they all have disadvantages. So let's be honest about some of these systems of what they can and cannot do. Clinicians need to understand what they can and cannot do, and they're different. One system is not the same as the other system, so they're all a little different, and that's one of the kind of drawbacks. You're responsible. Physicians are responsible for the care of their patients. The computer is not. You are. So take responsibility. And all my colleagues do. I'm preaching to the choir now. You just take responsibility, because if something goes amiss, with patient care, they're not going to go to Microsoft and say, by the way, your super medical intelligent, whatever it is, told me I had this and I don't, because it's wrong 20% of the time. They're not going to go to Microsoft. They're going to go to you as the clinician that's taking care of them. So, that's kind of some of the real overarching things here.
So I'm really hearing keeping the physician, giving them empowerment, to keeping them, at the center of the loop, the decision, the end executor. They're the executive of the decision making. It should, but the only thing I say is the argument to them, then I always feel like everything we try to do is giving them more work. Sounds like more work from the clinician and us. So that's the only worry. Like, I guess upskilling, I would say office upskilling, NPs, PAs, helping to, how do we alleviate that? I feel like the doctors are then left with the short answer of the stick.
Well, a lot of the problems with that kind of issue is also design of the systems that they use. These systems were created for billing. Long ago. That's all they were created for, billing. Now they do other things, but primarily it's to get a bill out. They weren't created to augment what a clinician does every day. That has just started. So when we do more and more of that, we're going to take less of the burden off of their plate so they can focus on patient care. Let the billing be done. That's the thing that's done in the background.
Well, this has been really good having you come on.
Thank you. It's been a pleasure.
I feel like we've answered a lot of questions, but we've opened a lot of further questions. We did not solve 238Q4 regulatory scribe AI questions, but we've definitely got some guidelines that this does need to be like I guess we asked, the UK could have given us socialized medicine. We probably aren't going to take that today, but we could use them as guidance on medical device as a service and look at it and where are we at this point, you think, with US using that? Or I feel like tech has too much of a holding right now to let that happen.
We're not anywhere close to doing what the UK did. Not even close. But we're going to get there. I mean, it's going to take a lot of fits and starts. My hope is that a lot of patients aren't swept up in the problem, meaning they get misdiagnosed or whatever, something bad happens. And I hope a lot of physicians don't burn out in the process of getting there. But it's going to be slow. In the United States, it's just going to be slow.
Well, Dr. Jay Anders, thank you so much for coming on today. I really appreciate you sharing with us this important challenge of getting AI right and keeping the patients safe and keeping the doctors at the center.
Thank you so much for having me.
Till next time, friends.